Welcome to the Hospice and Palliative Care Virtual Grand Rounds. Uh, I was reflecting the other day that this is the beginning of the fifth year of the series. So excited that we have this community and that we get these lectures to anyone interested. And I am uh, very excited. Wanted to make sure to announce our conference, which is going to be in March in Columbia, South Carolina. Uh, See if your city has a direct flight, but it should be great. Have some really good speakers. I put a link to it in the chat. We're accepting abstracts at the end of this month. If this is your first time here and you're looking to get CME credit or AVIM maintenance certification credit, there will be some links 45 minutes after the hour, a text-in code. If you haven't set up a text-in code yet, just shoot me a message and I can point you to the right place. And for MOC credit, you'll need to fill out a survey. But we're excited today to have Heather here. Heather Menzer is a social worker, holds a doctorate in social welfare, master's of social work, and postmaster's certificate in palliative and end-of-life care from NYU. She is the advanced care planning program manager at NYU, where she is responsible for patient and staff education, process monitoring and evaluation, and the program's research and quality improvement efforts enterprise-wide. She's worked in healthcare for over 15 years and throughout her career has focused on direct practice, clinical supervision, and educational efforts in support of patients and families facing serious illness at end of life. She has a private practice specializing in anxiety, depression, chronic and serious illness, grief, and loss. Heather has presented nationally and has been a leader in clinical social work within healthcare. So Heather, thank you so much for being here and welcome. The floor is all yours.
Thank you. Thank you so much for having me. Let me go ahead and share my slides. I trust you cannot see my notes. Is that correct? Great. So I'm really, really thrilled to be here today. This is a topic that I just really enjoy discussing with other people and presenting on whenever I can. And I'm going to tell you a little bit about why. I'm going to start by telling you just a bit about the objectives for today. We're going to talk about the emotional and psychological effects of losing a caregiver on children. We'll talk about the challenges we face as healthcare providers in supporting families during this time. I'm hoping that we have a group of different types of providers here, so hopefully everybody will find something relevant in this. We're going to talk about the benefits of preparing children for the death of a caregiver and how that affects long-term mental health outcomes. And then we'll learn some strategies for actually doing the work for preparing the children and the families for the death of a caregiver. So before I go forward, let me tell you a little bit about me and about why I'm interested in this work. As you heard, I have a doctorate and a master's degree in social work from NYU. There's me at my graduation this past May. I've been a social worker for about 16 years, and of course, I have a specialty in palliative care, and that's really where my heart is in this work. Mostly, I've worked in inpatient care, and now I run a program, as you heard. So about a decade ago, I was the primary social worker in the medical ICU at NYU in Manhattan. And I started to notice that I had these young patients coming in that were really, really sick and often dying on admission, patients in their 20s, 30s, 40s. And many of them had dependent children at home. And I started to think to myself, I'm an adult palliative social worker. That's my specialty. I really have never worked with kids. What are we supposed to do with the kids that are involved here? Whose job is it to actually prepare these children or bring them in? What am I supposed to do? Am I supposed to engage with them? So I asked around, I spoke to my supervisors, I spoke to other social workers, I spoke to my pediatric colleagues, I spoke to social workers at other hospitals in the city and other people I knew. And I found that mostly it seemed like this work wasn't really being done, at least in our institution. We had a really wonderful group of child life specialists and social workers who focus on work with children when children are sick, focus on work with siblings of children who are sick. But it started to occur to me that this isn't the same process when the parent is sick or the caregiver is sick. And so it turned out it was kind of nobody's job. And as I became more and more a part of the palliative world, and I started to meet many colleagues and go to conferences and present and do research, I started to realize this is something that kind of lives in the middle of two palliative care worlds. It lives in between adult and pediatrics. Pediatric social workers, at least in my institution, do not cross over into the adult world to do this work, nor do the child life specialists in our institution. They are hired by the children's hospital, and they don't come over and do adult work. They might like to, but that's not part of their scope. And then for those of us in adult palliative care or adult social work or whatever we're doing, where we're working primarily with adults, many of us don't have training in how to talk to kids about serious illness because that's really never been part of our specialty. So it started to occur to me that I needed more of a process. I needed to figure out what I was supposed to do and how to do it as somebody with really no experience working with kids in this way. I imagine some of you do this work already, and I'm really hopeful that you'll share what has worked in your institution. And then there may be some of you who really have never broached this work, or you don't have anybody on your team that's doing this work. So hopefully there's something here for everyone. What I want to kind of get across is that there's 4 main points to this, as far as I'm concerned, that my research and my experience has shown me. And a lot of this is backed up in the literature. So let's go through kind of my 4 main points. First is that the loss of a parent is pretty universally acknowledged to be one of the most stressful events that can occur for a child. So that's the baseline. That's what we're working from. What we also know is that children who are prepared for the death of a caregiver will do better in the long term. And we're going to break this down in a minute. We know that parents and children, when asked, say they want help from healthcare professionals in navigating these really difficult conversations, these really difficult times. And yet, overall, healthcare professionals don't feel equipped to help in these ways. Before I move forward, I just want to talk about the word parent, caregiver. I'm going to kind of use those interchangeably as I go through this. I want to use a really expansive view of the terms parent and caregiver. I'm thinking about anyone who considers themselves a parent, a grandparent, any other family caregiver of a child, a guardian. I want to acknowledge that family systems don't operate uniformly. We see patients from many different backgrounds, many different cultures and religions. And there are certain groups that are going to endorse very close relationships between adults and children, even if an adult isn't specifically in a parental role. So essentially, if a child considers this person to be a caregiver, then I am considering them a caregiver for the purposes of our work today. So what's the scope of this issue? How much of a problem is this actually? So let's look. I don't know if all of you are familiar with Judy's House and the JAG Institute's childhood bereavement estimation model, but it's something that comes out every year. It's a really, really great resource for finding data on the scope of this issue nationally and in your state. They come out with it every year. They break it down by state. It's really great. And what they projected for 2024 is that 7.4% of children in the US will lose a parent by the time they turn 18. And if you look here, I think it's interesting to think about the top 5 causes of parental death, because if you are somebody who works in a trauma hospital or a system that accepts trauma patients, you work with cardiology patients, oncology patients, you work in an emergency room, then you are likely seeing people who fall into this category all of the time. Let's also think about the fact that they are probably using a much more narrow definition of caregiver than I am. So this is likely a big underrepresentation in terms of numbers. Since I was invited by my friends from South Carolina, I took a look at their data according to the childhood bereavement estimation model. And according to them, in 2024, 9.4% of children will lose a parent by the time they turn 18, which if you see as it's compared to that green line, you'll see that that's higher than the national average. And what I think is a pretty giant percentage of 16% will lose a parent by age 25 in South Carolina. So that's a lot. So this is really something we want to be considering when we're thinking about taking care of our adults. Okay, so we know a bit about the scope. You heard my points. What does this tell us? Well, in my mind, it gives me a goal. And that goal should be to give healthcare professionals the training and the tools to support these families. And that's everybody involved in these families. That's the sick parent. Those are the well caregivers as well, and the children. And we want to, as much as we can, as much as we have access, give this support from diagnosis through illness and death. And that is our goal. And why do we care so much? What are the risks of doing this if we don't have intervention with children prior to parents' death? Well, the interesting thing about this work is that there have been a number of studies, and there's a lot of literature that has actually looked at what happens to these children when they grow up. We've been able to ask adults who were bereaved of parents as children. So we really are able to go to the source and find out the information from them. And what we've learned is that the loss of a parent can have striking, unfortunate consequences for a person's entire life when steps haven't been taken to intervene during the time the parent is ill. And I think it's important to think about our institutions. How many of us are actually doing this? Are we actually intervening with the child before the parent dies? And what we know is that these children, if there's no intervention, are at much higher risk of many issues: substance abuse and mental health issues. That's anything from anxiety to affective disorders and mood disorders to major mental disorders, schizophrenia, bipolar disorder, depression. And we know that this risk is even higher for children who already had mental health concerns prior to the death of this parent. So this, of course, can lead to lower stress resilience. It can lead to loneliness and isolation throughout someone's life. And of course, it has a negative effect on relationships. Everything from that child's ability to later trust others and to their feelings about themselves, to how able they are to express feelings. And of course, it can have a negative effect on academic performance. So as you can see, it seems so important that we are intervening with these kids when we have the chance. So let's break this down a little bit and talk about each group here. So let's start with parents. Now, some of you may have experienced what I've experienced, which it's not 100% of the time, but a lot of the time, the way that parents are dealing with the devastation of a new diagnosis, especially one with a poor prognosis or a terminal prognosis, is that to protect their kids, they're not disclosing. They, of course, have good intentions. They want to help their kids. They want to help their kids feel as good as they can. And a lot of parents think it's better to just not tell them what's going on or not tell them until we have to. And that's the instinct that many parents have. We're going to learn in a minute why that instinct tends to be not what is recommended in the literature, especially when we talked to people who have been bereaved when they were children. What we know is that, what we know is that parents want to protect their children. When a parent gets diagnosed with a terminal illness, there's so much to think about. They're thinking about their own mortality, they're scared, they're angry, all of these things, but also it can affect their relationship with the child. They may feel guilt, they may feel overprotective, and all of these responses do run a risk of derailing the child's trust in the parent as a reliable protector. And so we really need to think about that. And as I said before, when we look at the research, it overwhelmingly shows that parents and caregivers and children want help from professionals to guide them through this time. And more importantly, that parents that do receive this help and do receive resources, they will report less distress during this process, which of course is what we're always trying to achieve, right? Is to reduce distress for people. So now let's look at the kids. First of all, when we do include children in the process, and we're including them in the diagnosis and we're talking to them about what to expect and all of these things, we can have a really positive effect on the family as a whole. They can really enhance the functioning of this family. Whereas before I said the way a parent reacts can erode trust between parent and child, when we include children, it can actually improve trust within the parent-child dynamic and in the larger family. Families can become closer, they can become more resilient, and it's a really important opportunity that we have to correct any inaccurate information that a child or a parent may have. And I'm going to get into that more in a minute. It also allows us some time to coordinate with a child's school if that's something that the parent allows us to do or something we can encourage the family to do themselves. Schools turn out to be a really crucial partner in all of this. And this is something I really had to learn for myself as I went through it because it started to occur to me, who's telling the school? Is that my job? Is that the family's job? Is that someone else's job? How does a school even know this is going on? I've talked to many guidance counselors, principals, teachers who had no idea that these things were going on at home. And it really allowed the school an opportunity to provide extra support to these children. And then, of course, we know the children themselves can experience positive benefits when they're included. It's interesting, they've been children that have been talked to after they've lost a parent when they were included in these processes have shown to be able to express gratitude for the things they have, even while going through this really devastating time. Children in general who are included feel more valued, they feel less guilty, and they actually have an easier adjustment after the death. And so that is a crucial, crucial piece. So we can't forget, of course, about our well caregivers in all of this. A well caregiver could be a spouse of the person who's sick. It could be, any other adult, a sibling, a parent, whoever else is there for the patient and is there for the child. This is one of those things that I found really, really interesting when I looked into it, because it felt like there were pretty simple interventions that I could do that could potentially make a really big difference for families. The thing is that in an ideal world, we're helping a parent to both process their own illness, deal with their own anticipatory grief, and promote some kind of positive connection with their child at the same time. Not everybody's able to do that. Sometimes people are so devastated by their diagnoses. We know people grieve in all kinds of different ways. They really can't focus on making that relationship the best that it can be or maximizing it. And this is where the well caregiver can come in. The well caregiver can actually be a mediating factor in these situations. For those of you, for my social workers and my other mental health people who may be familiar with attachment theory, you may recognize some of what I'm about to talk about. One of the theories that we have in child development has to do with how children attach to caregivers when they're babies and they're young children. And our goal is to help children securely attach to adults. It helps them feel safe in relationships. And amongst other things, it helps, for families, for people to have good relationships with their families later on, to have meaningful relationships, to feel safe in relationships as adults. But what's interesting is that attachment style has the risk of changing over time. So the point of me saying this is even if a child is securely attached to a parent or a well caregiver, when they go through a really stressful event, like an illness of a parent, the death of a parent, they are at risk for their attachment style to change. That means a securely attached child can become insecurely attached or anxiously attached later in life because of the death, because of the way the illness is handled. And even if that parent isn't able to do the things that they would need to do to kind of maintain that secure attachment, the well caregiver can do that. The well caregiver can serve as that consistent source that helps this child maintain a secure attachment. And we know that that can have effects for the child's whole life, and it can have effects on that child's children eventually and that child's grandchildren. It's a big deal. And so when we're thinking about how we're supporting the well caregivers that we see, it's not just, are you taking care of yourself? How are you doing during this time? It's important to actually educate them on how much of a role they will eventually play and how this child does after the death. They can do so much to mitigate adverse effects for this child by dealing with their own grief and making sure they maintain that positive attachment to the child. So we've talked about the scope, we've talked about the different parties, in this these situations. So what's the ideal state? What do we really want? Well, we know that parents and well caregivers want help in talking to their children, and they want it from us. They want healthcare providers to be able to do this. They want the resources that are available, and they want coaching. And if they get that, we are likely to reduce their distress going through this process. What children want is they want to be involved and they want to be informed. And they want to be informed in a timely way. So This is something we have to balance because we know that when we give a difficult diagnosis and prognosis to a patient, that they often need time to process that. At the same time, we know from all of these adults that we talk to who were bereaved as children that they want to hear the information as early as possible. So part of what we can do as healthcare providers is help to provide that balance. When is the right time to give the adults some time to process, but to really get the children involved in a way that makes them feel like they're part of the process? When we do talk to children, they want to know about the illness itself. They want to know what's expected to happen to that parent. And importantly, they want to know what's going to happen when the parent can't serve their parental role any longer. They want to know everything from who's going to make my lunch, who's going to take me to soccer practice, who's going to pick me up from school, to perhaps if this is a single parent household, or if this death is going to result in this family having to move, where am I going to go to school? Where am I going to live? Who's going to take care of me? These are things that help children feel more safe, and children need to be informed about all of those things. I'm going to talk about the actual interventions, but before I get there, it's really important we talk about equity for a second, because we know, those of us that work in palliative care, that there are major end-of-life disparities in healthcare already. We're talking about families who are from a racial or ethnic minority family. We're talking about LGBTQ plus families. There's already a lot of healthcare disparity. That exists in this world as well, unfortunately. What we know is that when racial minority children do experience the loss of a caregiver, they're more likely to experience that death at a younger age. We also know that they are at higher risk for adverse outcomes later in life. And those relationships have been looked at, and it has been shown that those adverse effects will affect this child's relationship with their own children when they eventually have their own families. So again, we're really talking about trying to mitigate potentially intergenerational trauma and patterns that could really be mitigated by intervention prior to the death of a parent. And so I'm really thinking about this as a health equity issue. This is something we should be offering to all families, and we should be offering it regardless of background, religion, preferred language. This is something that needs to be done across the board, because there's a real missed opportunity when we don't do that. All right, so let's get into interventions for a second here. When I think about how we intervene and when we intervene with families that are going through these situations, I really think about 4 intervention points. Kind of 2 intervention points in the outpatient world and 2 intervention points that are more in the inpatient world or potentially the hospice world. So there are those patients that we are going to meet who have a longer time to live. We're likely meeting them in a cancer center, in a clinic, outpatient somewhere, and they have a prognosis of years. And there are those families that we're likely still meeting outpatient, but they have a shorter time. Their prognosis maybe is 6 months, maybe is 8 months. It's something limited. It's probably less than a year. And then we have those patients that we might be meeting inpatient in the hospital. We have those patients that we're meeting last days of life. We may never have intervened with this family before. Maybe no one has intervened with a child. This patient is on hospice or being considered for hospice or just generally in the last days or week of life. And then we have those families we're meeting around the time of death. Maybe it's the day the patient dies or the night before. Or sometimes I've intervened with families right after the death has actually happened. That's kind of what I think about as the intervention points. No matter when we do intervene with these families, to me, there are 3 stages of how we do this. And this is something to remember. Again, if this is something you haven't done before and you're thinking about starting to do it, think about it in these 3 stages. The first stage is gathering information. We need to figure out what is going on, what is the landscape before we can even think about what to do. And for many of us, that's going to start by making sure the family has the right information. I'm a palliative social worker. I've been on a consult team. So I know what it's like to walk into a room where I'm not part of the primary team and I'm kind of hearing what's going on and I'm hearing what the family is repeating back. And it's occurring to me that they don't really understand the landscape of what's happening. They don't really understand how dire the situation is or how poor the prognosis is. So we need to really interview the teams, interview the family, and make sure everybody's on the same page. There may need to be a family meeting that happens before we can even consider intervention with a child, because it may be that the adults don't really get what's going on. It may be that with all good intention, the team hasn't really been able to communicate that. And so that's our first step here. We're going to gather that information and we're going to make sure everybody has the same information about the medical situation and prognosis. After we do that, we need to find out a little bit about the child. So we need to figure out how many children are at home and kind of what the general situation is, but we also need to know what the child might already know, what the child might already have inferred, and most importantly, we need to assess the family's willingness and interest in discussing the illness with the child. After all, it's their family. They're in charge. If they don't want to do it, we can't make them do it. Or if they don't want to do it in the way that we want them to do it, we have to respect that. But we can still gather the information and provide some education around this. So here's an example of a checklist that I've kind of created with some colleagues to help me figure out what kind of things I want to know about a child before we move any further into this process. I need to know their ages, not just their chronological age, but most importantly, I need to know their developmental age. Because the way we discuss death and grief and loss and illness with children, of course, depends on their developmental age, what they're able to understand, what they can tolerate. So I need to know that information up first. I need to know what they've been told about the patient's illness. And if they've been told anything, I want to know the words they've used. So as we'll learn, euphemisms can be very, very hard for children to understand. So I want to get a sense of what's already out there, what we think the kids understand, and what you're comfortable allowing your kids to know. Is there anything you don't want them to know? Because we want to make sure we don't spill the beans on something that families aren't comfortable with us saying. Importantly, we need to know if the child has any experience with death already. Maybe they've had a death in the family. Maybe they've had the death of a pet. Maybe there's an episode of a show they watched where there was a death, or they read a book about it. Anything that we can connect our conversation to can be helpful. And if they have no experience with death, we want to know that too. We want to know if the family is comfortable with using the words for death and dying. Do they already use those at home? Do they have any beliefs that are important for us to know? Will they be saying that daddy went to heaven? And if so, we want to be able to use consistent language. And then generally, what is the support system? What are the family dynamics? What else is going on that we need to know? Once we have that information, we can start to develop a plan for ourselves about what kind of information we want to provide to this family. Now, for me, an adult palliative social worker, again, I didn't really have an understanding of what a 5-year-old would understand about death versus a 13-year-old. So I asked some colleagues, I got some resources, and there are many out there that are really good to learn. And so I sometimes will use something like this, which is a chart that helps me kind of look at generalities of what children understand about death at different ages and what grief responses might look like. Of course, this is a loose guideline. It may not fit exactly every person, but it gives me some sense of what may be going on and what I can warn a family about. You don't have to memorize this. I don't memorize it. Sometimes I even give it to families. I don't necessarily use this exact one. I have a number of different resources depending on what the family is asking for and what I determine that would be the most helpful. But something like this is really available out there and can be really, really helpful when you're talking to families. What we know is that many children don't grieve the way adults do. Sometimes adolescents may grieve closer to the way that an adult would expect. But many children, they don't grieve that way. Their brains are different. They have different responses, different reactions. They may have delayed reactions. You can talk to a 5-year-old and they'll just say, okay, I'm going to go play with my blocks now. And they're not sad. They're not appearing to be sad. They're not crying. This is normal for children, but it can be really shocking to adults who aren't ready for it. So anything that we can do to kind of normalize these processes for the adults in their life is really helpful. So you can carry this around with you, carry extra copies, have it in your phone, whatever, and refer to it whenever you need. So now we have the information we need. We know the family has the right medical information. They're ready to engage in some kind of intervention. And we know the developmental ages of these children. So now we can move on to providing education for them. We want to make sure that the family understands what we understand about how important it is to talk to kids. We don't want to bully them into it. We're not going to force anybody to do anything. But in my experience, when we share what we know and why we know it, families become pretty engaged in the process. They want to help their kids. People want this to be as easy as possible for their kids, and they want that help from us. And when we provide it and we say, look, there's actually a lot of research on this, and here's what it says, people often respond to it. We need to guide them through it, though. Sometimes that's going to mean I have to write step by step down what I suggest they do. Other times I'm going to be there with them, or I'm just going to tell them what to do and they've got it. And there's people at all different kind of levels of this where some families feel really comfortable doing it and some don't. So we're going to provide as much hands-on step-by-step guidance as a family needs. And before we actually do that intervention, we're going to encourage families to start planning ahead. This is everything from our general advanced care planning stuff that we recommend every family do, your healthcare proxy, your power of attorney, all of that. But we also really want to think about planning ahead in a way that affects what the children are going to need. I've unfortunately been at bedside at the end of life for many people who have realized it's too late to get guardianship for a child. It's too late to deal with their assets and make sure certain money is going certain places. We want to help remind families that they need to think about these things early on. We also want to help families to plan for what's going to happen if the parent needs to go to the hospital, if they need to go to certain treatments that are far away. Perhaps this is a disease that's at risk for unexpected hospitalization, and that well parent is going to need to be at the hospital to support that sick parent. What's going to happen to the kids in those situations? Is grandma going to come over and sleep over? Is the child going to go to a friend's house until their aunt can pick them up? Whatever it is, we want to have that information ready to share with children because they're going to be curious about it and it's going to help them feel more safe. So how do we actually communicate with these families? What do we actually do? Lucky for us, there's already some concepts that are considered to be best practice when talking to children about parental illness. Of course, we said we want everybody to be on the same page. We have to make sure the adults are okay saying the same types of things to the kids. Because as much as we can coach them through maybe an initial conversation or be there for an initial conversation, kids are going to ask questions later. We want to make sure the information they're getting is consistent. We want to make sure it's honest and it's consistent. So we want to make sure that the main adults in this child's life are on the same page about what's going to be shared, how to respond to questions, what words are going to be used. Then, of course, they have to be developmentally appropriate conversations. What a 6-year-old's going to understand is going to be really, really different from a teenager. And part of that has to do with the fact that younger children don't understand the permanency of death yet. And so kids that don't understand that yet, we have to talk to them a little bit differently. One of the things that I think about a lot when I'm having these conversations is this child still in the realm of magical thinking? Magical thinking, for those who don't know, happens when children whose brains are really smart and they're really trying to make connections between a cause and effect, create things in their mind to make something make sense. Now, it may be a far-fetched idea to us, but it's something in their minds that makes sense. The way I really think about it is their brains are trying to understand why this happened. As very egocentric humans, as they're supposed to be, kids often will relate what's happening to their own behavior, to themselves. So we want to make sure that we're slicing right through that magical thinking by providing facts. We don't want a child to think that because they didn't go to bed when they were told last night, they made mom get hospitalized. Mom got diagnosed with cancer because I didn't do my homework yesterday, or I told mom I hate her, whatever it is. So it's really important that we are using clear language with kids when we are cutting through that noise. We are saying to them, this is nobody's fault. You didn't do anything to cause this. Mom didn't do anything to cause this. Dad didn't do anything to cause this. We're making sure that the facts are out there so kids understand how to relate in these situations, and that they don't feel that they're blaming themselves for what's happened. We also want to make sure that if the family is comfortable, we're using the words that are real. We're using death, we're using dying, we're using chemotherapy, we're using cancer. When we use euphemisms, it's very confusing for kids. The amount of times I've heard stories about, when I was a kid, they told me my grandmother was sleeping, and then I was afraid to go to sleep for 5 years. Or, they told me my mom is always watching over me. And then I got in the shower one day and I thought, is my mom watching me? These are the kinds of things that kids will think. And so when we use the actual words for things without using euphemisms, it's really clear, it's really concrete for kids. If we have one of those really great grids like I showed you before, we can help families understand potential reactions that they might see short-term and long-term. We can also involve the schools at this point so they'll know what to look out for. And we also want to make sure that parents know it's okay to be emotional when they're talking to their kids about this, that we want them to model appropriate grief because this is a really sad thing. This is a really hard thing. And it's totally okay to feel devastated by this news. It's okay to feel anything you're feeling. But if that is sad to mom and dad, then it's okay to be sad too. And that can be really important because some families feel like they need to be really stoic around their kids. But actually, it can be helpful for a kid to see that emotion. All right, so now we've gathered the information, we've provided the education to the family, and now we're going to actually get to the intervention stage. That can include many things. Your intervention may be that you're coaching the family in how to tell the kid about the diagnosis at home. Maybe you're doing something in the hospital, you're helping to make a memory. Maybe you're coordinating with the school. Maybe you're doing a visit at the hospital. There could be a lot of different things you can do. All of these interventions need to be trauma informed and they need to be at the right time. So one of the questions I get asked a lot, and I wonder if any of you are wondering about, is should we let children come to visit the hospital? Is that okay? Should we be recommending that? Should children visit? And I'm interested to hear what everybody else thinks about this. My answer is basically maybe. What the research has shown is that kids want the option. They want the option to come and visit. They want to be told it's okay if they do, if it's okay if they don't, and then they want that to be supported. Of course, we have to make sure parents are okay with this. If parents are okay, I recommend that they offer the child the option and go from there. If the child wants to visit and you're going to bring a child in, there's a few things I recommend you do. Number one is you have to prepare the unit. I have made the mistake in earlier parts of my career not doing this. If you work on a unit where everybody takes care of adults, try bringing a kid up and see how everybody freaks out. People cannot handle it. They lose their mind. They just don't understand why it's happening. They get really sad. It's very hard for everyone. So I usually recommend that it be discussed at morning huddle on that unit. I will go up and talk to the direct caregivers, generally the nurse, and find out if they're comfortable. Have they done this before? Have they had a kid come in the room? I give them some advice on what to do if the kid asks them a question they don't want to answer, and how that they can kind of deflect that back to me. And I will always start by meeting the child outside the unit first and preparing them for what they're going to see when they go in. Sometimes people have a lot of tubes and things coming out all which way, and we want to make sure kids understand that that's going to happen. Sometimes kids will walk up to the door of the room and look in and think that's enough and walk right out. That's fine. We want to give them all these options. I always recommend that there's an adult buddy assigned to each kid, especially if we're talking about last days, hours of life. The child may be ready to leave the room, but the spouse may not be ready. So we want an adult buddy that allows each kid to come and go as is comfortable for them. And I generally recommend that you have some kind of activity there, especially if you have younger kids, just crayons and something to write on. Maybe they want to leave a drawing in the room for the person. Have something tangible that the kid can do if they need to get out their energy a little bit. So when we're looking at these 4 intervention points, here's an example of what this might look like. Let's say we're meeting somebody outside in the cancer center. This is a long-term patient, so their prognosis is likely over a year, maybe 2 years. We can start slowly. We can start by acknowledging how devastating this is. We can just start to get to know the family. We can talk about how their life is now going to change, maybe with treatments, maybe there's going to be functional differences at home, maybe the adult will have to start sleeping in a different room, whatever. We want to start talking about these things. And we want to start making kind of planting the seeds initially of talking to children, perhaps including the school, and really just talking about what this might feel like long term. And then maybe we're going to make a plan to check back in a week with the family and really start the work with kids. But we have some time. You can get that information slowly and give them a little bit of time to process. Short term is similar, but we're going to scooch everything up a little bit. We might need to get some more of those conversations on earlier, especially if this is a disease where we think that the capacity of the adult will be affected sooner rather than later. We want to see if there's any memory making or legacy building activities that we can do while the parent still has the energy to do that. So we might want to move that up and try to talk about, here's a timeline I really recommend for you talking to your kids about what's happening or bringing them in. So that's what short term might look like. Let's say you're meeting somebody in the last days of life. This may be an injury, a devastating accident, or it could be, and this has happened to me, a patient's had cancer for 7 years, but no one's ever told the kids. The kids know something is weird, but they don't know what it is. And you're now meeting them for the first time, and you're in this position to help the family disclose what's happening. So we want to do this, obviously, quickly. We want to help coordinate as much as we can. We want to be really active in that, making sure we have a conference room, making sure we have the adults involved to make sure the kids are taken care of when they come. We may need to facilitate some memory making or legacy activities at bedside right away. We might need to help kids say goodbye. We might need to offer options for kids to say goodbye. That may be anything from painting a picture, writing a letter, leaving a voice note, coming to the bedside and talking to the parent privately. I've told kids, you can say goodbye in your head. You don't even have to come to the hospital to do that. But we want to give them that opportunity and, again, the options to say goodbye. And then similarly, if it's day of death or the death has already happened, you may have to coordinate that final visit if the child wants to do that. You may need to be in the room helping the well parents or the well caregiver actually give the news to the child if they're not able to do it. So that may be something you have to do at the end of life. But even when that happens, there is a little bit of time to perhaps do a little project or something so that there's a token you can give to that child. Of course, there's many things we do now. We can print out EKGs and other things to give to families to make jewelry out of later, or people get tattoos when they grow up. But also we can do these little art projects. Here are some examples of things I've done. Or my team has done. I haven't done all of these. If you see those little canvases, what those are just very simple thumbprints, one of the parent and one of the child that make a little heart and they can take it home. That's something you can do post-mortem. The child doesn't have to be in the room, but you could do that for them with just these little pads and ink. That's all you need. And families tend to tell me that it feels very meaningful to them. So these are examples of things you can do. So overall, let's say you don't have this at your institution, at your site, and you're thinking, where do I even start? So these are some things that I did, and I hope that this would be helpful for you. And these are some recommendations I have. Find out if the work is being done at your institution. Maybe if you're like me, you work in one of these big institutions that has lots of sites. Maybe somebody in another site is doing this. Where are they doing it? Who is doing it? When are they doing it? Find out all of that. For me, I had some child life colleagues at the hospital, but I've also reached out nationally to talk to many people who are doing this across the country because I just wanted to get a sense of how other people were handling this. If so, if there's nobody on there on your team so far or in your institution that does it, think about who on your team has the skill set to potentially do this. And frankly, who's brave enough to do this? Because this is scary. If you're not used to doing it, it's really hard. I find it hard too. I've done it a lot now, and I still find it really hard every time. I generally do it with a buddy. I'll have a chaplain friend come with me or another social worker because sometimes it's just overwhelming. Sometimes I'll kind of train the nurse that's with me and we'll do it together. So, who might already have skill sets that fit into this? Who might know a little bit about child development? Who knows about family dynamics? Or who wants to take this on? We also have to make sure that our team members have time to do this, especially the last days of life, end of life patients. Sometimes this can take me half a day or a whole day, which is a huge ask in a hospital. But as we saw, the importance of intervening is so much so that to me, it feels necessary somebody do this. So, how do we allocate kind of job duties for the day to free somebody up to do this important work? And then what resources do we need to have for families and for us? What kind of grids do we want to have about child development? Do we want to be able to hand out books? Do we want some of those memory making activities? Do we just need crayons and coloring books available for kids when they visit? And where are they? Who has access to them? Are there some simple things we can order and have on hand in case we need it? So that's how I would recommend people start. And that's what I have for you today. And I'm really, I'm hoping there's questions, but I'm really hoping other people will share with me what they've done in their institutions too, because I think that's the best way for us to really learn together about how we can provide the best service to these families.
Thank you, Heather. Awesome
So thank
lecture.
you.
Um, if you have, I did put in the chat a link to the CME code and the survey, which is what you need to do for ABIM maintenance certification credit, or just to give feedback on the lecture. If there are questions, you can either put them on the chat or unmute and talk. I know Heather was hoping that we could share a little bit about, what we do at our various institutions in terms of caring for these children.
Thank you, Heather. That was very helpful. We actually do a fair amount of what you recommended in terms of giving the option is something it feels intuitive working in this work to say, hey, well, you need to ask them if they want to come and then prepare them for what that would look like. But I've noticed that a lot of parents and families haven't even considered asking children if they want to be here. And that's been something that is kind of a slight shift in the language we use that I've seen be very helpful, where parents may be adamant of, I don't want my kid to see my loved one this way. I want them to remember the way they were. And we might have a conversation about that and that worry, but maybe recommending giving the option, especially for older kids. And just you can see the light bulb switch of, oh, that makes so much sense. So this is very helpful. I'm having my colleague behind me is going to be joining me shortly to actually go do a visit with an end of life visit. And we just found out the patient coded a couple times. So it's going to be a little bit more closer to end of life. So this was very opportune time and help. So thank you for that.
Thank you for sharing that. I think I see that all the time too, right? It makes sense. Your loved one is intubated and you think, I'm going to bring my 9-year-old in to see them. I mean, it doesn't feel intuitive for people. And I totally understand that. And I think when we are able, like I said, to share some of that data that we know about, because we've been able to learn so much from people who have been through this situation, it's powerful. We don't want to convince people to do anything, right? That's not our job, but we just want them to have the information they need to make the best decision for their family. So talking to families about why we would offer an option and how that would work, sometimes it's powerful. And, we don't shame them if they don't want to bring or they don't want to offer the option, because sometimes we know as, palliative social workers that people are going through every single feeling ever at the end of life or when their, loved ones are dying. And sometimes people just can't get there. And that's okay. But we want to be there to offer the information.
Is there any handouts you would recommend for patients and kind of the well caregiver to kind of maybe summarize this or give this information in a different way? Because I find that they're very overwhelmed at times, especially upon initial diagnosis. So I just wanted to see if there's any recommendations for parent handouts.
Yeah, I've started to put together some resources actually, which I'm happy to share. I started a Google Drive of some resources that I'd love for anyone to add to if they have anything else. And so I'll be happy to share that with everyone after this. And a lot of it is getting your own language that you feel comfortable with, just anything like anything else, kind of practicing how to approach a family that may be overwhelmed. Maybe you're going to start by just planting a little seed. Sometimes I'll find that the patient and the spouse are so overwhelmed that I'll ask if there's another adult that might be able to help with this, some like a close aunt or something like that. And maybe I'll talk to them about it and they'll lead, kind of be the lead with the child. So that's another option. But yeah, certainly I'll share those after. I don't know if you all saw the chat, but Cinda from Baylor Scott and White was talking about her program that they have, and she has been very gracious to give me a lot of advice in my journey here. So I certainly recommend anybody look at that program because they're doing some really amazing work.
Heather, I so appreciate this presentation. I formerly was in Mount Sinai in New York for 10 years. I worked with Jennifer in the palliative care program there, and it was a resource-rich program with child life therapists. And I'm now in San Diego at a small community hospital, and I found upon coming here to work about a year ago that it was the need of supporting the children was an unmet need here. And I quickly found what an exciting and rewarding opportunity it was to create a program, but also for me, someone who had virtually no experience working with children, it was also very intimidating. Again, at Mount Sinai, I left it to the expertise of our child life therapists, and I often observed their work. And I'm so appreciative of the work of those child life therapists and of social workers such as yourself, because you help support those such as myself who do not have a lot of experience or expertise in this area. And so thank you immensely. Thank you.
Thank you for sharing. Yeah, that's kind of what I experienced too, was that we have these wonderful child life therapists. They're amazing, but they don't come over to the adult world. And I didn't really want to do this work, frankly, at the beginning, but once especially I started looking at the research and literature, I thought, oh my gosh, I can't not intervene, because the long-term effects that children are at risk for when there's no intervention is so gigantic. It started to feel like if we can mitigate any amount of that, even if the patient has just died and I'm just meeting the child for the first time, we have a responsibility to do that for people. And if that means I'm doing it, fine, I'll have to just do it. So I really encourage all of you to consider it if you're working with that population, no matter what your discipline is, because you have some of that skill already. And everything we do here, I think is helpful as long as we're doing it in a trauma-informed way and we're making sure we're using the right resources. There's no reason why we can't be mitigating some kind of, potentially long-term disaster for these children that can then affect their own families and et cetera, et cetera.
You say trauma-informed, and it makes me think so much about how what a balance this has to be between like honoring the expertise of the caregiver, especially in the context of like being involved in healthcare and us being so paternalistic, and how nervous children make everybody, and like so concerned that I mean, in my experience, the providers around me get very nervous and almost like more paternalistic than I've seen them before about what we need to do to fix the distress of the child. And it's like to really be able to like provide the information and also like go with the speed of the family, even if we think that it's not going fast enough or in the right direction. And also to be culturally responsive, because people have lots of different ideas about who should have any say over how their kids cope or learn or I don't know if you can say anything about that.
That's such a good point. Thank you. Yeah, it is a very delicate balance, like everything at the end of life. I mean, for any of us that are palliative providers, we know that there are so many situations that we wish that we could tweak a little bit, but the families aren't there yet. And that happens here too. I think we have the added difficulty, like you said, of perhaps dealing with the emotions of our team who aren't used to seeing kids come to the floor. I mean, the amount of times I've brought kids up, it's like every time the team really reacts in a way that you would expect anybody who doesn't understand this to react. It's shocking to see a 6-year-old walk into the room of a patient who's actively dying, that it can feel instinctively wrong. But when we explain of these things to patients and families and teams, they usually, I say more times than not, I feel like they do get on board. But like you said, I mean, families have all of this pre-existing stuff before we even meet them. They may not be ready. They may not be there. Teams may kind of freak out. I mean, that happens. And I think those cases particularly are important for debriefing after, or whatever word you use in your institution. Some kind of discussion can be really helpful after to make sure that everybody understands why we did it, how it went when the child was in the room. That can really make everybody feel like they're part of the process and understand it better. So that's something I recommend people do as well.
I was wondering if you could, if you've had any experience, or if you could address if you've worked with or have information on working with children who have parents that are either lesbian, gay, transgender, if you found any differences or approaches that might be different than working with others.
I don't have that experience, so I don't want to speak on that particularly. Yeah, I don't know. Does anybody else have something to share on that?
I think, Darren, you texted that you come in late, and one of the first things Heather did was acknowledge that, the LGBT community, QIA plus community is certainly has social determinants of health. They may be underserved and under-resourced, so it's important to give more attention, right, for equitable care.
Yeah,
I guess
sorry,
the only thing
sorry, my tardiness.
No, you're fine. Yeah.
One thing I will say is that actually my doctoral work all centered on supporting the LGBTQ plus community at end of life in terms, especially of advanced care planning. So what I will say, at least about the pre-planning phase for these families, is that there are other things that families have to think about, whether they have children or not, frankly. But when it comes to end of life care, perhaps hormone replacement therapy at end of life, how kids may be part of legacy may be affected differently, especially if our patients are going by a name or a gender not assigned at birth. We want to make sure those things are honored. We want to make sure kids understand. And so kids may need to be part of the process, even of obituary writing, the way that we talk about people at funerals, what tombstones look like. I mean, that part could be important, especially to honor chosen identity and all of that. So that's, I think, all I could offer you on that point. Well, thank you so much for having me today. This was such a great opportunity to just hear from you. And I really always appreciate when other people are doing this work too, because it can feel lonely. So I really appreciate this opportunity.
Absolutely. I will stop the recording.